response to the measures, and how we could better understand and respond to the way people are dealing with the spread of the virus. So without further ado, well, perhaps two more important announcements. One would be that we would appreciate if you keep your microphone off when you're not speaking. So I see that all the microphones are at this moment off. This is good, but I would actually raise the quality of the sound and image and everything. And the second is that we would appreciate if you could share your questions as much as possible in the chat section. So that would give me the opportunity to select some questions and also curate the questions and deal with them in the session. But if there would be some urgent matter that you could not put on the chat and you would really want to actually sort of discuss it in the session, you could raise your hand so I can see that. But again, a request to everybody to share as much as possible in the chat section so that we could also share with the speakers later. They might want to come back to your question, respond to your question at a later stage. One final remark is that the session is being recorded as we speak. Of course, we have the permission of our speakers for the recording. So the recorded session plus the presentations will be on the website of the Delft Safety and Security Institute. So you could consult the recording there, but we also need your permission for going ahead and recording. So this is a call for to ask to make sure that everybody is comfortable that a session is being recorded. Our speakers have already kindly agreed to this recording, but if you speak especially and if you turn on your microphone or turn on your camera, it's good to know that you are being recorded and that it will be broadcasted on the website of the TU Delft. I forgot to introduce myself. Apologies for that. So my name is Anatol Itten. I am the scientific director of the Delft Safety and Security Institute, and the Delft Safety and Security Institute is organizing the second day of the Safety and Security Week at TU Delft. So the week is organized, as I said, as a part of the national important event. And safety and security are both matters for the practice, but also from the science and academic perspective. The focus of the session right now is more on understanding the virus and understanding people's behavior. So without further ado, I would like to invite Panchami to share her presentations. Well, it's already on the screen, and to take the floor and give us her first talk. Panchami.
Yes. Good afternoon, all. A small correction. I'm actually a postdoctoral researcher as well. So I actually defended my thesis in February 2020. So just
apologies, the website was not updated. Apologies about that. Congratulations.
Yeah. So in the next 10 to 15 minutes, what I will do is share the results of one of my study, which is data-driven epidemic modeling in public transport network. And I don't think we need to talk about why it is important in 2020. I think we are all familiar with COVID, and I hope you're also familiar with the term contact tracing. The contact tracing, there has been different solution which has been proposed worldwide, which is both popular and unpopular among the citizens, mainly due to privacy reasons. And why it is so is that for contact tracing, what we need to do is we need to build a contact graph, which tells you who a person have come in contact with. And this person who you're tracing for can either be infected or non-infected. And there are a lot of solutions, as I said, and mainly like apps, which is the main reason for the privacy concerns. And the premise for this study was that there are existing data sources that we can use either as proxy or actually give these contact graph. And this is especially true for public transport networks, where we have these smart card data. So I hope you know the OV chip card data. And this is there is also in other countries, you have smart trip data or which is in Washington, DC, but in Sweden, you have the SL card. So the smart card data is there. And with the smart card data, what you can do is that you usually tap in at a location and tap out. And in the field, what we have right now, we can infer the trajectory of that traveler based on the smart card data. So there is already data. These methods are available. And so that's what our premise was, that we can use this existing data source to create the contact graph. And that's what we try to do it in the study. Now, when you travel as a traveler, there are 4 potential points of contact during your journey. It can be when you tap in at the origin station, you can inside the train when you're actually traveling, and then you can also meet another person at the transfer station, and then finally at the destination station. So what we have done is to decompose that traveler's trajectory into these 4 points of contacts. Now, thus, given these data, which is essentially your tap-in location and the time, the tap-out location and the time, and the inferred trajectory, we can actually build a contact graph from this data. And so what we've done is so now we have the contact graph. Now we can describe how the virus may spread in this public transport system. And for this, we had to build an epidemic model, which have parameters and assumption. And some of the parameters, which is really associated with COVID, was the incubation period. So this is actually the data that or the non-parameters we got when the virus hit in the first time in March. So this was the data that we had, which is you have 5 days of incubation period. That's when you show the symptoms. And then at the time, it was 21 days of quarantine time. But now it is only 14 days. So these are the parameters that we use for our model. And of course, there is also a parameter which is specific to COVID and public transport, which is the possible states of a passenger, which is susceptible, exposed, then they are infected, and traveling till they show the symptom. And when they show the symptom, they quarantine, and then hopefully become immune. I mean, there are studies which says that you don't really get an immunity from COVID, or there are small cases of it. But in this study, we assume that people become immune. Then, of course, we also have model assumption, and we have 2 model assumption, which I think you can really relate to. One is related to the 1.5 meter society that we talk about. So, and the other is related to how many passengers are really infected in the system. And the 1.5 meter society, I think you can easily say this is what we came up with in the beginning was if you have a system like this and a system where 1.5 meter is like it's regulated, then the probability of you being infected will be less in this case. And this is essentially the function that we used. Now, this is a really strict function. What we say is that anybody if you are near to an infected person within 1 meter, you are infected. So this is a really, let's say, a worst case scenario modeling, but you can easily change this function to change the results of the epidemic modeling. And the next one we had, the assumption that we had is the number of people infected in the system. So this is, for example, is 3 out of 28 people is infected, whereas in this case, it is 3 out of 7. But when you combine this 3 out of 7 with the probability of the distance, because here they are all holding the 1.5 meter, so the probability of being infected, let's say 0. So we use a combination of these 2 probability to find the probability of a person being infected. Now, we applied our model on data from Washington, D.C., because that was the data that we had. And what we did was in Washington, D.C., there is in the metro network, there is almost 600,000 people traveling per day. And on average, there are almost 133 people on the train at a given time. What this means in contact graph terms is that there's almost 337 million person-to-person interaction. I would say possible person-to-person interaction, not really person-to-person, just for the morning period. So just for this 270,000 travelers, there is 337 million interactions. And this is an example of a 1 person traveling. So this red that you see is the person traveling just for 8 minutes in a train for 3 stations, but he was already could have been potentially in contact with 1,000 other people all over the network. Now, this really shows how highly connected the public transport network is, because it was actually built for this purpose to have high connectivity and efficiency. But this is where the COVID is also quite efficient. So this is why we should consider, so this is why we have to regulate this. Now, um, what can you do with these contact graphs? So one is, of course, the epidemic modeling, but you can also actually find this is like the ridership on each link at different times. And the more red it is, let's say 700, so 700 people is traveling in that certain link. The more red it is, the more vulnerable, or the less they cannot do the 1.5 meter distance anymore. And what the travelers, the transport managers can do is try to find which times these problem occurs and which link, and try to regulate for this link, these links. And so these are different uses of contact graphs. But of course, you can also use it for epidemic modeling. And what we did was we used the model parameters and the assumption that we had, and simulated for, let's say, 3 people was initially infected in the system, and what happens, like how does the virus spread through the network. And what we saw was that just 3 people infected with 3 different trajectories, after 5th day, all the at least one person have traveled in the whole network within the first 5 days who was infected. So this is how just 3 people infected, and they could cover the entire network within 5 days. Now, this is the whole entire modeling of the simulation, what we did with 3 people. And what you see is that this yellow line is the daily infected people. I hope by now this graphs are familiar to you. If not, this is, for example, is the daily infected. So no new infections is only possible after 45th day. And what you see is that so I think you all have seen this one, which is the first wave or the second wave, as you say. So this is one wave. So after the 45th day, there was no new infection. But just 3 people being infected initially, it could already do 55% of the whole entire, this 270,000 people were infected. So 55% of that people is already infected by it. Now, what we can do is, of course, is also look at we call it the state metrics. But what you see here is that the red is where people get infected. So first it was only 3, and how do they their states move? So they first become infected, then become quarantined, and then immune, and then they go back into the system, right? So you can, of course, cut down this epidemic model to see what is the each state of the people as well. Now, we checked, of course, first 3 people are infected. What happens if 3,000 people were initially infected? And this is what you see is that this graph becomes shifted. So before, no new infections was 45 days. Now it is 25 days, which looks good. But what you see, of course, more people get infected faster. And this relates to essentially what we call the flatten the curve that everybody was talking about. Because now, immediately on the 5th day itself, there is this high peak of a lot of people getting infected at the same time. What this means is that there is finite resources such as medical resources, and then suddenly those will become congested, right? There will be a lot of demand for that. So this really shows you how, of course, it is nice within 25 days there is no new infection, but because of the resources that we have, that's why the importance of the flattening the curve comes in. Now, we tried it for different scenarios, of course, where you have different infection rate. And what you see is that, of course, as I said before, the number of infection days becomes smaller, but for the same amount of people. So this really, again, relates to the flattening the curve problem. Now, what can you use this for? So what we have done is that, of course, assuming that all people travel the same, just 3 people infected could already do 55% of the whole population in the public transport system can get infected. But we thought, okay, what happens if you change the demand? So we don't allow people to travel. So for example, the work from home was implemented. So what happens then? So this is like the different scenario. So we can try different scenarios on this epidemic model and find out the answers to those. Because this is the final slide that I have, and what we saw was that, for example, when the 70% is 70% of the demand is there, you can have a small infection rate, and that it gets really also dissipates faster, the virus. And that's for certain demand. So you can think about it like, what happens if we suddenly close the Utrecht station? Because that is really one of the highly connected stations, right? And if you say, okay, if you decrease the demand there, we can decrease the infection, how the infection spreads across the network. And this is essentially what you can find from this kind of modeling is, okay, where should we decrease the demand? And you can do operational management with these kind of networks. With that, I come to the end of my presentation. And what I really wanted to come across is using this kind of existing data sources to do contact tracing and what we can do with these kind of models. So I welcome any questions that you have.
Thank you very much, Panjami, for the very interesting presentation and for sharing your data with us. Perhaps one quick question before we open up the floor to questions from the audience. And again, the chat section is open for any questions, but also you could raise your hand if you want. So in your model, you say that based on 3 infection, there were 2 things. One is that based on 3 infection, you could show that after 45 days, there was no infection left. What it couldn't follow entirely was that based on 3,000 infection, that the curve was flattened much faster. What was happening there exactly?
So the curve was, of course...
Maybe you could go back to this, oh yeah, you're very good, thank you, sorry.
Yeah, so here, of course, it doesn't flatten the curve, but the new infections comes really fast. But what happens is the number of people who are getting infected increases, right?
But those infected will keep infecting others. And based on 3,000 infected, that would be an escalate. So I don't see the cascading effect of 3,000 infected in this graph. Because
what you see here is that it indeed, let's say 55% is infected here within 45 days. Sorry. Whereas in the 3,000 case, 60% is infected within 25 days. So what you see is more people getting infected in shorter time period.
But are we assuming that those infected will be in quarantine and they will not come out and infect others?
Yeah, so that is the assumption of the model, is that on the 5th day, they see the symptoms and they will quarantine.
You mentioned earlier, of course. Yes, of course. Another question about the assumption in the model. Are you assuming that the 3 or the 3,000 who might infect the others before knowing that they are infected, they are wearing any kind of protection? Are they wearing a mask? Or is that the assumption is that they're just being unprotected, walking through the trains or the...
Yes, so at the time when we were doing the research, there was actually no studies about COVID. But later, actually, this was released in 2020, where they showed what is the infection risk if you were wearing mask and physical distancing. So this is one of the things that we also did. And what we saw that, for example, for some of the simulation that we did, the the virus can spread up to 350 days. That's almost a year. But the thing is, less people, so the number of people being infected is almost the same, but it is across multiple days, right? So then at least the medical team will not be affected that much, and the resources will not be affected that much.
So your model is a means to help actually the regulator to take off the pressure of the medical means and resources, basically.
Yes.
The very famous IC beds mostly, or access to the hospitals, which might be a big problem in metropolitan areas.
Exactly.
Very good. There are 2 more questions coming in. The first question is, how does your model relate to the reality? For instance, to infection clusters in public transport, because that does also happen a lot. Does your model take those things into account?
Not really. Well, so it's really hard to relate. How does it relate to reality? Because we are only finding the contact graph of people when they are in the public transport. not when they're outside, right? Because of course, these infected people also travel outside. So it's really hard to relate that to the reality because we are only seeing half the truth, essentially. But the idea was that these are the places that needs to be monitored the most. The public transport network, grocery, for example, where you're doing grocery, because these are the places where there is a lot of crowd in a small space. So indeed, it's really hard to relate to the reality, but it is mainly for people like the transport modelers and like, for example, the grocery chain to like make sure that they regulate the crowd. And this is one way to do it. So because, for example, what we saw was really interesting is the scatter plot that we saw, and that even with 70% demand, you can have the 70% demand if you manage it well. You can keep the infection rate and the percentage of people infecting low just if you manage the demand well at specific time and at specific locations.
The next question deals a little bit with the same issue regarding actually have you validated the model based on real time and actual data? How does the model actually deal with compare with other virus spreading events of which we have actual data? Because that would be an interesting way to sort of validate your model.
It's really hard to first of all find those studies. I assume that now there are a lot of papers being released with the COVID results, but at the time that we were doing, there were not that many studies that we could relate it, because most of the thing that we can do, of course, is related to epidemic models, normal epidemic models, but they don't really use a data-driven contact graph behind it. And that is the main difference between this study and the others, is that we had an actual contact graph. We could actually use the demand that we had was the reality, and we can use that as the input to the epidemic models. And so there were nothing that we could compare it against. But if there is anything that you can think about, let me know as well. It would be really interesting to research further.
There is a lot of actually sort of talk going on and on new data being published based on actual events and actual spreading events. It might be very interesting to sort of compare those data and to see to what extent your model is compatible with the actual events.
Yeah.
Another question that also it's more like a remark, but also a question, maybe something that could be considered for sort of making the model more sophisticated in the future, is that some passengers, specifically maybe the younger ones, if you look at a public transport right now, they do behave differently. For instance, walking through the train is a sort of you're spreading even the virus further than once while you would get to one seat there and leave the train afterwards. So those are again the individual behavior. Could the model one way or the other factor that in, or is that the model is looking at the aggregation of number of people with a virus entering the public transport?
No, I think the model can definitely include more assumptions, because what we can do is based on the idea is that with our tap-in card, we can also essentially get their age. We don't have this information because they are really privacy sensitive, the smart card data, and they don't really provide us with, for example, we cannot track a person through multiple days. That's not possible. We just have, okay, this is anonymous card ID and this is the thing. But ideally, we can also get the age and all the things associated with the personalized card, right? Such as
metadata, probably that is not
exactly.
Privacy sensitive. Yeah.
Yeah. And then what we can do is per age group, we can have a different assumption, essentially, a probability function associated with it.
But your model is only looking at the entry and exit places, so you don't say anything about how a person behaves while traveling in the public transport, right? The model cannot have any kind of assumption about how a person is going to walk around this train or not. If a person who's infected goes walk up and down twice in a train, I think that could easily become a super infection event. What is the term they use for that? A super spreading event.
Super spreader, right? So we essentially, as I said before, we had 4 potential point of contact, right? What we can do is what you said is this will only happen inside the train, right? So inside the train, you can have a different probability function because the model is so simple. We don't have any assumption on the contact graph. So it's mainly about, we can make it more sophisticated by having more data-driven assumptions for these different things. So we can just have, for example, inside the train for these categories have a different probability function.
Right. If the model is to predict also behavior, how the person behaves in the train, the potential points of contact should be increased or must be increased actually. Yeah,
exactly.
Very interesting. That would actually demand a whole change of the public transport system. Maybe like having another point of entry when you're entering the train.
Exactly.
Yeah. I see that we have room for one more question. So let's see if there is any other question from the audience. If not, I have one. What's your next plan for how are you going to actually continue this research? Are you going to continue sort of making this model more sophisticated, or do you have other interesting research ideas at this moment?
So one of the things that we wanted to try is because now we have the digital twin, which we'll probably hear later on, but which we can actually get the contact graph for our university. So we can try to do the epidemic model essentially also in our university contact graph and see where is this potential vulnerable locations, as well as do like different scenarios there as well to decrease this virus spreading. And I think that will be really interesting because we have different kinds of data there.
Yeah. Thank you very much. Thanks also for referring to the digital twin session, which is coming up at 2:30. At 1:30 we will start with the digital twin session, which will be given by Professor Deborah Nuss and Dr. Sascha Hogendoorn. More about that you could find on Delft Safety and Security .nl, the Institute's website. I would like to thank Dr. Panchami Krishnakumari, postdoctoral researcher at TU Delft, and apologies for the wrong introduction in the beginning. Apparently I had consulted the wrong webpage on the TU Delft website. Thank you very much. Please stay with us. Maybe at the end of the session, the next talk, we will have a more common Q&A session with the three of us. Dr. Anatol Itten is actually our next speaker, who will talk to us about life after the lockdown and how TU Delft could engage with the population in the Covidexit scenarios. Anatol, can I give you the floor, please?
Yes, thank you very much. I hope you can hear me well and see me well.
Excellent.
Yes, I would like to kick off my presentation with a short explanation movie that we just finalized. It's you're the first kind of trial audience that we share it with. It's still a few little twists we have to do, so it's kind of almost finished, but I thought it's a good introduction into what we do. It's actually, as Benham said, it's research we do mainly, Nick Mouter is the head of the research. And what we did in relation to Corona, or the Corona exit, was together with Shannon Sprite, so colleagues of TPM, and a number of other colleagues and also experts, of course. We're a big team doing this together in a very short time period. And I just thought we made an explanation video how our approach works, but also especially on the research that we did. So I thought it's just a good way of sharing this and easy to start off the presentation. So let me share this with you, put on the sound and the video, and as Evelyn said, you can also otherwise click down if you see the video only in a small screen so that you have it in full screen. So if everything should work now, you would
imagine you are the boss of an organization.
The video. Okay, I will start it again.
Imagine you are the boss of an organization, a local politician, or the prime minister of your country. You want to make good decisions, right? To come to a good decision, it's important to know what the preferences of your people are. Obtaining people's input is possible through surveys, focus groups, or town hall meetings. However, such methods often provide only limited information, or they are time-consuming. Scientists have now developed a new advanced method to investigate the preferences of larger groups of people. This method is called Participatory Value Evaluation, in short, PVE. Basically, it works like this. Participants take a seat in the decision maker's chair, virtually. Being in this virtual environment, they experience a policy dilemma of a decision maker. They see the policy question with several policy options. Also, they see the impacts of each option. Just as in reality, these options face a constraint. With this information, they are asked to give their advice to the decision maker. To give an example, the Dutch government had to decide whether the corona measures should be relaxed, and if so, which measures should be pursued over others. In the PVE, Dutch citizens were presented with a number of policy options. They were also able to see the effect of each policy option, like the number of new infections, mental stress, or the loss of income. The constraint was that the pressure on the healthcare system could not increase by more than 50%. In less than a week, 30,000 citizens eagerly advised their government on what it should do. PVE reaches a large and diverse group of citizens because its entry barriers are low. Participants generally take about 25 minutes to submit their advice when and wherever they want. And PVE has more benefits. PVE increases public understanding of policy choices, and it allows people to express a nuanced opinion. Moreover, it provides detailed quantitative insights into people's preferences for policy options. The Corona experiment delivered up to 150,000 written arguments, which can be analyzed using algorithms to obtain detailed insights into the motivations and worries of citizens. Do you want to learn more about PVE? Check out tudelft.nl/PVE.
So I will now share the presentation. I hope it worked well. Let's see. Oh, that's wrong. Okay, I think if everything works well, you should now see my presentation. Yeah, so if you want to know more about the study, it's also in a shortcut. It's just Covidexit or TU Delft/Covidexit. And I'll tell you now a little bit more after the video what we did and why we did actually include citizens in Covidexit research. Because there's in literature, often three reasons why you should include citizens, not only in research, but also in policymaking during a crisis. And there's, of course, the normative point of view, because the decisions that were faced during the lockdown, they're very critical and also facing uncertainty, of course, but they also have a really big impact on everyday life of a lot of citizens, and also especially on vulnerable groups. So they also create winners and losers by taking decisions, and so participation should be a citizen's right to kind of at least give a voice or be consulted about these really high impactful and very value-laden decisions. But there's also, of course, substantive reason, because there's so many ideas out there. People know really their location well. They know also their behavior well. So they can also give a lot of insights into ideas and into concepts. So you should actually achieve also better decisions when you consult individuals. And there's, of course, especially during a pandemic, a very instrumental reason, because compliance is so important. So you also actually want to know how people think about it, and if they can understand what you propose, and if they accept it or not. So just the example, if you would introduce a contract tracing system, app, etc., and people think it's morally not compliant, or it's morally deplorable, or also not compliant with their daily life. So then it doesn't really make any sense, or at least the impact is not very strong. So there's certain reasons to do that. We did that also during a time where it was the lockdown still in place. So there was during April, between April and May, we did the study, or the first study. We are now doing a few months more. I will explain that in the end. But what we did then, so there were around 8 proposals on the table, which corona measures should be relaxed, as said in the movie. And so we did this online platform, we call it PVE, so that the citizens can see the different options. And that's kind of a screenshot, it was in Dutch, how these options were presented. So everyone had access to a link, or we shared access, the link to as many as people as possible. We also had a representative panel, and we assembled a lot of information with a lot of experts, with modeling experts, with health experts, with experts from ministries, to really come to a quite realistic scenario. Of course, we also had to explain how much pressure on the health system would contribute if you select these measures to be relaxed. So we should also have a kind of, even if it's uncertain, slight or quite realistic proposition and advantages and disadvantages of each option. So that was the interface. Then we did a lot of promotion, as said, with the communications department, but also we spread it through a lot of media, so that we got a lot of people to participate, that we also tried to really open it up, because we saw that there was a really big demand of citizens also to participate, because they also felt, yeah, I also want to give my statement, I also want to be heard. So what we saw, that there was a lot of people participating in it. We only had this survey open for a week, because we knew that there was shortly an announcement coming of relaxation measures, or the Dutch Institute for Public Health really wanted our data beforehand. So we couldn't, normally we leave this open for 2 weeks or so, but we had to collect the data in 6 days. Around 30,000 Dutch citizens participated. I think it could have been more if the server didn't crash. That was also problems on our part. And what you can find out, so very simple results, of course, if you consider the advice of citizens, you can know what is popular and what is not popular, but you can also, of course, see a bit the nuances. So, for example, where is a bit polarized opinion, where it's not a clear picture. You can also see, like later on, of course, you could also see what is in line with the government policies. And interestingly is that the entertainment sector and restaurants was really not that popular to open it, and they pushed forward with it. So that's also, of course, something to consider now that we are heading in new soft lockdowns. What is actually has a lot of support, and where is also a lot of distrust. Interestingly, also proposals that were discussed to have like lockdowns lifted in several regions was back then very unpopular. So it was kind of either the whole of Netherlands or no one, so to say. So now that we also see that the measures were increased or expanded to the whole of Netherlands, that actually is also based a bit on these insights that there's quite big support, because it's also a very dense country, of course, even though you have the northern part that's not so densely populated, that there's kind of a big support for measures that are that spread through the whole country. There's also a lot of qualitative results, as you heard in the movie. We got over 100,000 comments and arguments. So what we did, we teamed up with a team around Kathleen Jonker, with Pradeep and another colleague, which I just missed the name, but so they helped us with machine learning and natural language processing. So we did a lot of coding ourselves in the beginning, just to know a bit about what we have to feed into the machine, but then the machine was going through to see about topics are actually important so that we didn't miss anything, but we also could see which topics are more like niche topics, which ones were more often stated. So then you see, for example, the motivation. So employees in contact professions should go back to work, so that we see what are actually the comments or like the arguments for the pro side, what are the comments on the negative side. But interestingly, what we first didn't really thought of, like, is that a lot of people raise conditions. Yeah, I am happy, or I support that employees can go back to work if there is sufficient protective material, if there is risk groups additionally protected, etc., etc. So we really considered or got a lot of insights that people were very aware that they don't just are in favor or against it, but they're often also state under which conditions they would be in favor or against it. So that really was really helpful for us to share it with policymakers. Then the colleagues which are more on the quantitative side of interpreting data, they could of course model also what policy sets would be the highest, would have the highest support throughout the population. And so you could see which of the different policy options, if you take the combinations together, also increase the risk on the healthcare sector. And you could see that, like, for example, now if you recommend this to policymaker, then you can see, of course, this the first one is like really the highest, the top policy set, but it's also slightly more, or like quite a lot, actually 10% more. So if you're a policymaker that's a little bit more risk averse, we would suggest and only take like relax these two measures. Also has really high support in the society, but it's less risk averse. You can also, what I don't have here, we could also already, of course, also dig in the subset of the population, because there's a lot of social data available, like from their socioeconomic status. So we find also out that, for example, young people in southern Netherlands were more in favor of opening bars and restaurants, of course, but that, for example, women were also more in favor to open up nursing homes. So then you can also know more about a specific subset of the of society. Interestingly, last insights that we also ask often, how much should this advice of you value in relation to advice of scientists? And you see that here, even though there's so many people ask, and they could, also state differently, a lot of the citizens say, yeah, my advice should be, only slightly valid. Advice of scientists it's more important than the advice of citizens. And that's quite different than in other research we do. There is sometimes more than half, but you really see a balance that only a really tiny bit of participants would say that only the advice of citizens should count, or that it should count at least more than those of scientists. So it's really also a backup of that policymakers can really listen to scientists. What we are still going to do the coming months or weeks, of course, very interestingly, to compare it with new lockdown measures, or at least the soft measures that we are experiencing now. Do we see also a change of attitudes? So it really be interesting to do this very soon again. But we also in contact with researchers from Ethiopia, for example, because they also really would like to carry out a PVE on the corona policy in their country. And what are we also going to do is, that's in preparation as well, to measure the preference of Dutch people for policy option to stimulate vaccination willingness, because there's also a lot of skepticism. And so we're doing a study there, if people like, which kind of option would they like to, under which options they would like to accept or not accept vaccination policies. Yes, that's from my side. Check out our research on and with this method on PVE. Yes, thank you very much for your attention, and I hope there are also questions to be answered.
Thank you very much, Anatol, for the very fascinating presentation. I have two questions. I have one question, another question that came in, and both actually sort of go to the same issue. One is that how does the model, how does your system, your predictive system account for socially desired answers? And the best example, perhaps in recent history, is that many polls that were consulting people could not predict the election of Donald Trump because people were judging the answer of answering the question or answer differently on the phone when they were being asked they were going to vote for that president. And that's an extreme example, but on different occasions, when you ask people what they say and how they act might be actually two different things. Do you factor that in or sort of correct for that in any way? Or you're just basing your argument, consider the vaccination example. I might not tell the person on the phone that I don't want my kid to be vaccinated, but I might have strong religious belief that might avoid me from doing so. Do you understand what I'm trying to get at?
Yes, definitely, and that's really important. There are 2 points to be made. So first of all, it's a very anonymous research, so they cannot be tracked because sometimes we also track or we ask information where they live, like postcode. Because it's really interesting to see really zoom in, but that was not allowed in this case. So we only could ask the region where they are. So that was actually the only kind of identification you would kind of have, but there was no name. There was also nobody calling. So it's really just an online platform where you can participate with a link and you can just fill in one time. So at least.
But how does that factor in actually correcting for these kind of social answers?
Well, at least you're not talking to another person. So it's nobody asking you what you're going to do. So it's really
right. Okay, you're reducing the social interaction so that the answers come as close as possible to the actual answers.
And they also know, if you would say, okay, at least, you have to give a lot of information about you, then you think you can maybe also be traced at least. But you also can do it, at least you don't have to do it, you have a week time, so you can also do it when nobody's around. So you don't have to, if you're somebody calling you and there's just in a room of people, you might also think, okay, they're now listening, but online at least it's quite anonymous, and it's not like that we cannot completely filter it out. But the other way, what is also important is, that's maybe the second point. It's also not, so we're asking their preferences towards policymakers and not about how would you behave in that situation. So it's not, it's really about that we ask them to be more like the citizens and not the consumer. So
right,
that's just,
right.
We are not modeling. The policymakers sometimes hope through our data that they can see, at least through preferences, that there is a higher chance that people would support this or that measure. But we also don't know if they will really behave, because that's not we're not tracing their behavior. We're tracing the preferences for policy measures, and they can give input and demand also for the policymakers. So sometimes we also see that people even know or want that. We also saw a lot of answers in when closing down or we're skeptical in opening up the restaurant and hospitality business, was because they said, I know that if I'm drunk, I cannot enforce 105 meter distance, because I know that I cannot do that because I will hug people. So please don't give me the opportunity to not kind of not respect the rules. So that was kind of a lot of discussion. So we could see that people also know that they're sometimes that's why they want to have regulations in place, or at least longer, because they know that themselves they cannot live up to the compliance that would be requested.
Excellent. So the huggers are being protected against themselves to be put in a position to actually sort of spread the virus in that way. But do you also factor in, that's the second question that came in, how people deal with each other's interest? If I'm a person who never goes to the bars and restaurants, my answer would definitely be keep them shut down for the next 6 months. And if I were an outgoing person, I would probably respond differently. So to what extent is your model different than only a majority rules kind of model? And would people also decide about each other's interests? Would people in Friesland decide whether people in Groningen are going to go into the next lockdown or not, in the way you're actually sort of carrying out your questionnaires?
Yeah, it's also very important. What we actually saw is that, if you zoom into the northern region, we saw that they're not answering differently than the rest. So they could also, even if we have aggregate results in the beginning, you can also then see, okay, so if we talk specific about the northern regions, do they answer this differently? Because we had then the provinces of, so the people, at least they would state where they're living or in which province they're living. So, and we saw that there was not a big difference in the answering. So that, of course, we see, because otherwise they're the ones who are, if the majority rules, but they're the ones with the most impact, because, or at least they also try a lot of higher costs because they're not a lot of infected, but they would also be in the lockdown. But we also saw that these people are not against or not answering this question differently than the rest of Netherlands. So there you can correct, or at least you can be attentive to these things. The second, what we really do is we really show that there's no kind of option that doesn't have a positive or a negative impact, or only a positive or a negative. So we all have we assembled with all the lockdown or relaxing the lockdown, that every option, like selecting or not selecting, has kind of an impact. So it's also that you really give them the dilemma that also the policymaker face. So we don't only want to say, oh yeah, I like it or not. So if you click on it, you get really if you select this, you get really the increase or decrease in deaths, or also in incomes, and through that, it's a bit what we want to stimulate is kind of that you really start thinking about if this is really what you want, and if it's getting too high. So if you would just think, I don't want to relax everything. There are also people, so they complain, why can I not just relax everything? I don't care. I'm young. I want to, or I have a Swedish mentality. I just want to be really open. That's just not possible, because the politics will never do that anyway. Even if people's preferences, it's not political feasible. So that's also why we make it as similar as possible as a policymaker evaluates these different scenarios. And through that, we hope, and we also see it in the comments, that people kind of really think about it and also try to have a bit empathy with other professions, or with the dilemma. Or sometimes a lot of people answered, wow, now I can really understand these difficult trade-offs from policymakers. I never thought about. I just think it's good or bad, but I never really thought about how difficult it is to make these decisions.
Very interesting. So the Swedish mentality, you're alluding to the fact that the way Sweden dealt with the virus was probably counting on people's support. That's your assumption. And the question has come in whether other countries have done similar research as yours.
We are just writing, actually, or finalizing a paper on that, where we also compared a bit. And the most close is actually Scotland. They had also a more deliberation platform on lockdown policies, so that there are different policies on lockdown, and people could, it was more like arguments, if that's really like a good one, or also problems. So they're under each get kind of this deliberation or this argumentation trees. So they came really close. There was also a Belgium survey, like a big Corona study, but they only had one policy measure in there with mouth masks. So they're more focused on the healthcare part, so how people feel. But they also had one question on policies. We had a few, we were also looking really into South Korea and especially Hong Kong examples, because they're very interesting. Both are very different, but very interesting. And we saw that South Korea did a lot of citizens' ideas. So for example, what we all know, the drive-through testing was an idea of a citizen. And because it leveraged this as a state or as a government, it was really put in place, and through that it also spread around the world. So South Korea also really tapped into the knowledge of their citizens. And Hong Kong was differently, because there was a really big tension between the government and the citizens. So the citizens really organized themselves, but that was not really so the policies was then copied from the government, from the citizens, but not really actively sourced. But so we are having a hope that we can circulate this paper soon, and there we also compare it with other efforts around the globe, and also with other techniques like with mini publics and with the participatory budgeting, and to see also how we how this method can be used in crisis policy making.
Very fascinating. Thanks very much. One last question, a practical on how you've carried out your questionnaires and the survey, and to what extent you have actually provided some kind of feedback. The question is, do you actually let people know how their engagement has been translated into the policy, because that might incentivize them to be more involved in similar studies?
Yeah, that's also, I mean, we're struggling already since I'm a student, like to connect citizen participation with the actual output. So what is the effect on it? That's still really difficult to measure, of course, because there's a lot of things we cannot control. There's a lot of black boxes in between. But of course, simple is just, or what we always do is, because we carry these studies often out together with or in like in commission of an authority. So people already, like, they very communicate very transparently. So we're doing this together, and also what happens with the output, that we share it with the cabinet, and that of course also happens, so that people know what is actually who is interested in their knowledge and what happens with the results, because that's already encouraging. Second is also they can always click that they get the results, and if they want to be updated. So that we always do, and they get also the study results. And in the end, we even cannot really control, because we shared it with the Dutch Health Institute. So, and they have a collection, like, that's, I can just tell you now how it works in the Netherlands at this for this study. So they collect a lot of studies, which they commission or they work on or they just send to them. And then they have a round where they just review everything, and then they collect what they want to share with the outbreak management team. So they shared also, so that we didn't get information on what they took from us, but we know that they shared our findings with the outbreak management team, and then the outbreak management team decides what they're going to advise. So there's kind of this loop we don't really know, and we can just compare what's then the outcome of the actual policies and what we advise the government.
It sounds like social impact at its best. Thanks very much for sharing your research with us, Anatol. Thank you very much, both speakers, Dr. Anatol Itten and Dr. Panchami Krishnakumari. You can watch the webinar. For those of you who joined later, you can watch the whole webinar on the website of our institute. That would be Delft Safety and Security.nl. And so the recorded webinars, along with the presentations and the contact information of both speakers, could be found there. And please do join us. In half an hour, we will have the next session, the next webinar on how engineering can help to shape the 1.5 meter society. And there is a lot of more interesting, fascinating activities happening in the Delft Safety and Security. And you can find a lot more information on that on the website of TU Delft. Thank you very much for being with us. Thank you, the audience, and hope to see you soon.